So good morning, everyone. Good morning. Dwayne Spencer again, President and CEO of Habitat for Humanity of Greater Memphis. Happy to see you. Welcome back to our Health and Housing Summit webinar series. Thank you for joining us. We are nearing the end of our second week. Can't believe it. And I hope that the sessions have left you as energized as they've left me. I'm really excited. So much work has been put into this event, so really excited seeing it unfold. If you've missed any of these sessions, I hope you go back and watch the recordings when you have a moment. So I want to again thank the sponsors who've helped make this event possible: the Tennessee Housing Development Agency, Wells Fargo, and Methodist Le Bonheur Healthcare. And then again, thanks to our advisory group who helped by giving us their expertise during the planning process. Appreciate that. So on to today's panel. So as I've said many times, Memphis Habitat is committed to continuing our work to provide repairs for low-income seniors. And I know many of the people here share in that commitment. Today, you're going to hear from other age-friendly states that have taken varied approaches to improved housing conditions for older neighbors. I've already learned so much from these folks as we were planning this event, and I can't wait for you to hear from them. So just a few quick reminders. Continue to use the chat, all right? And then use the Q&A function if you have a specific question for the panel. And then our team is going to hand those over to the moderator. And then feel free to tweet. And if you do post, use the hashtag TN Health Housing Summit or just Memphis Habitat. All right, thank you. So today's moderator is John Vick, Ph.D. He is the Evaluation and Assessment Director for the Office of Primary Prevention at the Tennessee Department of Health. In his current role, Dr. Vick develops practical data systems, frameworks, and projects to inform the department's primary prevention efforts. His work reaches across sectors to develop and leverage partnerships with government agencies, universities, nonprofits, and other community groups. So again, welcome to all of you, and I'll turn it over to Dr. Vick.
Great, thank you, Dwayne, and good morning, everyone. Welcome, and thank you for joining us this morning for the Spotlight on Age-Friendly States panel. So we will hear from three experts this morning who've implemented evidence-based programming to improve health and housing outcomes for their senior populations. During the first half of our session, our panelists will share case studies from the Gulf Coast, Minnesota, and Vermont. And we'll dedicate the second half of our time to a discussion and participant Q&A. So I think you'll find their work compelling and relevant for Tennessee as we learn how nonprofits, health systems, and government can use data and evidence to catalyze change in their communities. So before we get to our panelists, I did want to mention that here at the Tennessee Department of Health, although we do have some involvement in housing, it's not a big part of what we do. However, we all know that housing is an important driver of health. That's why we're all here today. And as the state's public health entity, it's important for us to continue to think about ways that we can support safe and affordable housing for all Tennesseans. We have noticed recently that a growing number of hospitals and health systems across the US, including several in Tennessee, are beginning to engage in housing-related work. And I wanted to mention that we recently conducted an exploratory study to better understand a little bit more about Tennessee hospitals and how they're getting involved in housing. Partly because we wanted to determine whether there's a role for us at the Department of Health to help support that work. We interviewed Tennessee hospitals that included housing as a priority in their most recent community health needs assessment. And what we found was that hospitals are taking a variety of different approaches in Tennessee to addressing housing needs. Some of these approaches include weatherization, home modifications, homeless outreach, eviction prevention, and even neighborhood revitalization. We asked what types of roles that they would like to see the Department of Health play in supporting some of their work, either current work or what they would like to do. And they identified some roles for the department, potentially identifying best practices, making the case for how affordable housing can benefit hospitals, convening stakeholders, data analysis, direct project funding, and program evaluation. And they generally expressed an interest in moving from individual level interventions to broader statewide systems change and policy solutions. So I wanted to bring this up because I think you're going to hear about a lot of these approaches today from our panelists. I'm really excited that we're going to have the opportunity to hear about their work, think about how these types of programs might be relevant here in Tennessee, and we'll have an opportunity to have some Q&A with them as well. So I would like to mention who our panelists are to begin with, and then we'll get started. So our first panelist is Alicia Sanders. She's the Director of Housing and Services Policy Research at L.N.H.A. Then we will hear from Dr. Rajean Moone. He's the Faculty Director for Long-Term Care Administration in the College of Continuing and Professional Studies and the Associate Director of Education for the Center for Healthy Aging and Innovation. And finally, we'll hear from Kathy Laborde, the President and CEO of the Gulf Coast Housing Partnership. So they've all turned the cameras on, can wave hello. Good morning, everyone. And we're gonna start off hearing from Alicia Sanders this morning. So Alicia, I'm gonna turn it over to you. We'd love to hear about the work that you're doing. Thanks for being here this morning.
Great, thank you, John. Thanks for the introduction, and thanks to Habitat for having me here. I am going to talk to you a bit today about the Support and Services at Home program, or SASH as it's commonly referred to. And then I'm going to talk to you first about some reasons why there's not broader state support for these types of programs, and then some things that states could consider around supporting these types of models. So first, telling you a bit about SASH. SASH was developed by the Cathedral Square Corporation, which is a nonprofit affordable senior housing provider in Vermont, along with some community organizations that commonly work with senior housing residents. So the model is centered on an on-site team at the housing property that consists of a full-time enhanced service coordinator. And for people who might not be familiar with service coordinators, this is like a social worker type role. And that enhanced service coordinator is paired with a part-time wellness nurse. And the nurse is not in a clinical role, but they're doing things like education and coaching and navigation. And the idea is that these two roles work together as a team to really consider the residents comprehensively and to be able to address their interrelated health and social needs. These teams also have purposeful partnerships with the Councils on Aging, which is what Vermont calls their area agency on aging, and the visiting nurse associations. These two entities are providing Medicaid waiver and other aging-related services to residents in the buildings. And so the goal is to communicate and collaborate among the common clients that in the housing property and that these organizations work with to really leverage each other's knowledge about the residents and their resources in the community. So the goal is to leverage each other and not duplicate each other. These teams also have partnerships with the health networks in their region. So Vermont has established a statewide network of primary care medical homes that are supported by regional community health teams. And these community health teams help support the medical home practices with things like care coordination, counseling, and health education and coaching. So they might be supporting residents who have diabetes or congestive heart failure or mental health concerns. And so they're really kind of bringing an extra layer of support to these primary care practices. And the SASH teams serve as extenders of these community health teams to work with the residents in the building and the other older adults they serve. And I'll get to that in just a second. So what these SASH teams do is they conduct a pretty comprehensive assessment of residents, looking at all of their health and functional and social characteristics and needs. And then they support them in addressing any needs that are identified and any interests that the residents want to fulfill. So they do this both through one-on-one assistance, and then they also bring group programming and group activities to the communities as well. And I should mention, I forgot to mention that these are all voluntary. Residents can choose to participate with the SASH teams and in any of these programs. So the state incorporated the SASH program into a Medicare demonstration that it got started in about 2012. And this demonstration was around these primary care practices. And the state was trying to support and bolster and build this primary care network. So SASH got incorporated into this Medicare demonstration, which allowed it to be spread statewide to over 100 senior housing properties across the state. And this demonstration went from about 2012 to 2017. So it was a 5-year demonstration. And what happens is the Medicare dollars pay for the staffing at the housing properties. They pay for the wellness nurses. And in some cases, they pay for the service coordinator, where a housing property may not have had a service coordinator before, or only had a part-time service coordinator and they needed to beef up the hours. So one condition of the Medicare funding was that they had to serve all Medicare beneficiaries. So the SASH sites actually serve the residents in the housing communities and Medicare beneficiaries in the surrounding communities. So in some cases, they do put some geographic parameters on there, but they're serving both people in the housing property and people that get referred to them from the community. The state also committed Medicaid dollars to the program. So in Vermont, Medicaid, the state has a waiver with Medicaid that allows it to share in some savings and to use those savings for health promotion activities. So the state committed these Medicaid savings to the program to help support the infrastructure of the program and training and programming for the SASH program. So as part of a team that was led by RTI International, my center evaluated the SASH program. And we found that over the 5-year demonstration period, the program slowed the growth in Medicare expenditures for participants in the urban areas of the state, which was about a little over half of the program participants. It slowed their Medicare expenditure growth by about $1,500 per year. And this slowing of Medicare expenditure growth was driven primarily by slower growth in hospital visits, emergency room visits, and specialist expenditures. So we also, in our final year of the evaluation, we also took a look at the Medicaid expenditures. And we did find that the program was able to slow the growth in long-term institutional care. So moving to a nursing home, they were able to slow that growth for about $400 per year for certain participant groups. This was mainly individuals that lived in more rural communities. So these were pretty good results, pretty promising results. And so after the Medicare demonstration ended in 2017, the state wanted to continue supporting the SASH program. So the state transitioned from the Medicare demonstration into and they worked with CMS to transition into an all-payer accountable care organization model, which allowed them to continue bringing in the Medicare funding and the Medicaid funding and the commercial insurance funding in a similar way to where they had before. And so now SASH is supported through this statewide ACO model. So SASH is still receiving the Medicare funding and the Medicaid funding. And one thing to note about how the Medicare funding is flowing, which is sort of unique, and it is hopeful that this could inform future payment models or future payment options, is the Medicare funding goes to the housing sites, to the SASH teams. So it's not billing as Medicare traditionally is done. It's not billed like it is by the doctor. It's not billed by the individual patient. It's going to the health teams, to the SASH teams to support the property level work. So The SASH program is unique, not just in the way that Medicare is funding it, but in that the state has an interest in Medicare spending. And this is because of its involvement in the all-payer model. So most states don't have any responsibility for Medicare. They only have responsibility for Medicaid. And so they don't have as direct of an interest in older adults' healthcare use, like hospital visits and ED visits, because that's paid for by Medicare, not paid for by Medicaid. So this is an important thing to understand, what Medicare pays for and what Medicaid pays for. For older adults, Medicaid pays for long-term services and supports like nursing home stays or home and community-based services. It does pay a few things relate for dual eligibles. It does pay a few things related to Medicare, but it doesn't have primary responsibility for their healthcare spending. And as you saw from what I said about the SASH evaluation, the benefits really accrued to Medicare in terms of reducing the expenditures or slowing the growth in expenditures for hospital use and ER use and physician use. There's a bit of uniqueness, as I said, to how that's funded, but we think that it could inform the development of new payment mechanisms at the federal level, or maybe opportunities through initiatives that are trying to better integrate Medicare and Medicaid. And you all probably know there's a lot of initiatives going on, a lot of different attempts and ways to see how we can make Medicare and Medicaid work better together for individuals that are dually eligible for both programs. And we know in housing properties, a large proportion of the residents are dually eligible. And some other work my center has done, we found that about 2/3 of residents in affordable senior housing properties are dually eligible for both Medicare and Medicaid. So there should be an interest somehow for states to think about how they might be able to support these residents in older adults, in older adult housing properties. So states could think about how they might incentivize or encourage health entities that are working with duals in their states. So even though they might not have immediate direct benefits and savings from the programs, do they have an interest in the older adults' well-being and health promotion and wellness activities, not only for their immediate, but maybe what it could mean down the line for them in terms of how their health and functional trajectory goes. So they might think about, could they work with these Medicaid managed care or the health entities, the hospitals, the health systems in their state that are involved in these alternative payment and delivery mechanisms, to see if they could encourage them to work with housing properties around coordination and wellness prevention. So really thinking beyond just thinking about housing as a shelter, which is incredibly important. And a lot of health entities have taken a big interest in this, but thinking not just about the shelter, but how care could be delivered from these housing properties or in collaboration with these housing properties to kind of amplify and leverage what they can do together. States, to the Medicaid supportive services, though, states might think about how they could coordinate the delivery in these housing properties a little more efficiently and potentially a little more effectively. There hasn't been really any evaluation of this, but we do know that in these housing properties, as I mentioned, there are many dual eligibles, and some portion of those dual eligibles are receiving Medicaid funded home and community-based services, which generally means they have some type of aid or personal care support, home care support coming in to the property. And often this is done in a very traditional way where each individual resident is organizing their own services, and they might have their own aid coming in Monday, Wednesday, Friday from 10 to noon. And you might see multiple aides in the building at the same time working with individual residents. But states might think about, is there a way to more efficiently organize that, where you might cluster this care at the property level with placing or stationing in some way aides at the housing property that serve multiple residents while they're there. And this allows for a little bit more flexible delivery of the time. So rather than getting care 2 hours a day, Monday, Wednesday, and Friday, they might get increments of care over the day. It also allows for potentially for fewer aides to be staffed at the housing property. And we know that a lot of states are struggling with finding the workforce to fulfill these programs. So there might create some efficiencies for states from that perspective as well. So Massachusetts is a state that it has a program that does this. It's called the Supportive Housing Program. This is a program they operate in state-funded public housing in Massachusetts, and they allow the area agencies on aging, which are responsible for coordinating the Medicaid waiver and state-funded home care in these states in Massachusetts. They allow them to pair a home care agency with a housing property and station aides on site to serve multiple people in the building. So states might think about, could Tennessee or other states might think about, is there a way for them to more efficiently deliver these Medicaid related services, in addition to how they might work with their health and hospital systems to think about the care coordination and wellness and prevention supports that are going to their dual eligibles. So I'll stop there and let us move on, and then happy to answer any questions later in our Q&A portion.
Great, thank you, Alicia. And remember, if you do have questions for our panelists, please go ahead and put those in the Q&A or the chat, and we'll make sure to get to those once each of our panelists has had a chance to speak. So next, we're going to hear from Dr. Rajean Moone. Dr. Moone, I'm going to turn it over to you to talk about your work. Thanks for being here.
Thank you, Dr. Vick, and thank you also to Habitat for inviting me to be part of this panel. I certainly wish that we could be together in Memphis, looking out my window at all the snow, enjoying what the city has to offer. We're having a bit of a warm spell here in the Twin Cities. It's going to get to 33 today, but we keep being reminded that last year at this time, the high was minus 45 degrees. So continue to think about the sun that you're probably enjoying. I don't know if you're aware, but here in Minnesota, we actually have a special place in our heart for Tennessee. Even if we've never actually visited, around 30 years ago, Tennessee flooded Minnesota's airwaves with commercials that sang "There's a Song for You in Tennessee." Some of you may have heard some of these. So almost all Minnesotans at this point can sing that song, and really subconsciously, we all have this pull to visit your state. So we have this romantic vision in our heads that you all play guitars and walk around with backup singers, but probably not exactly true. But my experience I'm bringing today comes from my work within state government, nonprofits, and now in academia in Minnesota. Minnesota is often seen as a great place to age. We're currently ranked #1 in the National Long-Term Services and Supports scorecard in our work with older adults and family caregivers. And we take pride in our work, but we also recognize that we have a long way to go. For example, our private philanthropic community, which includes big names like Target and 3M, only invest around 0.8% of their cumulative grant-making funds to services targeting older adults and family caregivers. The number is obtained from an annual survey of giving completed by our statewide Council on Foundations. Sadly, one of our largest non-government sources of funding for aging services, the Greater Twin Cities United Way, eliminated their annual $5 million allocation for grants for these services around 4 years ago. So to explore this challenge, as a National Health and Aging Policy Fellow, I formed a network called Finish Strong. The network consists of both public and private funders of aging services, and these stakeholders meet quarterly to establish strategic partnerships and work to expand funding for aging services. This network now rests under the auspices of the Minnesota Leadership Council on Aging, which is a membership organization made up of non-governmental entities who have a stake in promoting positive systems change and policy for older Minnesotans, their family members, and the direct care workforce here in the state. And while we do have amazing outcomes for most people in our communities, we know that it's not true for all. In fact, looking at the data, sadly, Minnesota has some of the worst economic, health, and social disparities between Black, Indigenous, people of color, and LGBTQ communities in comparison to their peers. It's been a long secret and one that we are exposing with our Department of Health declaring health disparities a public health emergency, and those health disparities being caused by the systems that were put in place that perpetuate these disparities. As a result of these staggering data points and facts, the Minnesota Leadership Council on Aging established the Minnesota Diverse Elders Coalition. This is a group of culturally specific providers that serve elders and their families. And they advise and they serve as an important consulting group to the council and state government when making decisions that impact older adults and particularly diverse communities. We try to think of our challenges as opportunities to innovate and be better. Much of this work falls under our framework of an age-friendly Minnesota. I'm a member of the Governor's Council on an Age-Friendly Minnesota, which has been charged with making recommendations to the governor on what we can do better to truly make our state age-friendly. And at the core of this, our work is driven by data and evidence. Over 2 decades ago, the then governor, Jesse Ventura, yes, even before California elected Governor Schwarzenegger, we somehow elected Jesse the Body Ventura, a famous professional wrestler. The great thing about Governor Ventura was that he was a strong advocate for older adults, and he established a long-term care task force that included constituents from our Senate, our House, and his administration. This task force explored the data that were available on preferences in long-term services and supports, demographic and economic trends happening in the state and across the nation, and other factors that impact our communities, older adults, and their families. The result from this work was a concerted effort to rebalance long-term care, like what's been happening across the US. Minnesota historically has had a very high nursing home bed per capita rate, and in fact, we're considered overbedded by our 2 nursing home trade associations. This rebalancing long-term care looks at decreasing reliance on institutional-based care to aging in place in home and community-based settings. So interestingly, the data today are just as striking as 20 years ago. We continue to use this data and evidence to explore how we plan our communities. For example, AARP's most recent national survey shows that 8 out of 10 adults age 50 and older want to stay where they live, but only 5 out of 10 believe they'll be able to stay there. Further, over 50% of older adults are rent burdened, which has seen a consistent increase over the last decade. Finally, when looking at older adults accessing their basic communities, while they represent roughly 20% of the population, they represent only 4% of park users. So this data just really make the case for purposeful initiatives targeted at older adults and family caregivers. But data are only valuable when used effectively. And I want to highlight 2 programs related to where a person lives that we created in Minnesota to continue to move the needle and support older adults to age in place. Knowing that there is a strong preference to remain in one's home, and knowing that higher levels of care are more expensive and continue to grow in cost, Minnesota leveraged its information assistance network for older adults called the Senior Linkage Line to establish the Return to Community Initiative. In general, people who qualify for Medicaid and waiver services can receive transition support to help them move from institutions back into home and community-based settings. But we asked ourselves, what can we do for people that don't qualify for Medicaid? Those that are at risk for spend down to poverty in order to receive necessary supports and services. Well, Return to Community utilizes social workers and public health nurses to identify individuals that private pay for long-term care to help them understand and navigate the wide range of long-term services and supports that are available to them in their home. An independent evaluation found that the Return to Community program successfully transitioned around 4,000 people from long-term care settings into their homes. There's the individual benefit that a person lives in their preferred setting, their home, and an added benefit of saving millions of dollars in the Medicaid budget annually. In Minnesota, like across the US, the cost for 1 year stay in a nursing home is just over $100,000. And we have a unique policy here in Minnesota called rate parity, meaning that you can't charge a private pay person more than the daily rate that person would get if they were receiving Medicaid. Even when you think about that, that number is really high when you add up the 30,000 nursing home beds in Minnesota times over $100,000 per bed per year. Looking at the data, we've then wondered, what about people on Medicaid that don't qualify for the waiver, that don't have access to those transition supports? Knowing that housing, a very strong and one of the best researched social determinants of health, greatly impacts a person's life, we in Minnesota made the case to the federal government to include a new housing stabilization services benefit in our standard Medicaid plan. We were approved and are very happy to report that we started our serving the first Minnesotans in this service in July of this year. We're now at just over 2,000 people. These people are receiving services to either develop a person-centered housing plan, to transition from an institution or from a more restrictive setting to home. And some of them receive the necessary follow-along support over time to maintain their housing without qualifying for the waiver. So again, it's just important to note that this is a standard part of our Medicaid program, the actual healthcare benefit that pays for things like hospitals and clinic visits and prescription drugs. And it's not part of a separate waiver that we had to request from the federal government, or that there are additional eligibility guidelines in order for an individual to qualify for these services. So these two initiatives point to the need to use data to make informed decisions about policies that have an impact on thousands of older adults and their families. These programs also highlight the need for strong collaboration and shared goals. Different state agencies and stakeholders who sometimes don't agree and sometimes have a very difficult time getting in the same room together, and most often have competing priorities of what's best or what's ideal, need to work together to achieve mutual results and positive outcomes for older adults. Both of these programs that I outlined needed collaboration with our State Unit on Aging, the state Medicaid agency, health department, housing department, the legislature, the university, area agencies on aging, counties and tribal governments, the federal government, and countless stakeholders. It's also important that we're all on board with the same measures and outcomes for success, because in order for a program to receive that political and community support, we need to measure the effectiveness and drive the results based on data. And we collect data using our state Medicaid information, but in addition, we seek out information that's more qualitative in nature about the preferences on where people want to live and receive supports and services. So we match those big data sets like the Medicaid claims data and service utilization data with data sets about individual stories and narratives to be able to craft programs and policies that meet both economic and demographic opportunities and challenges, but also individual preferences and family needs. So I want to thank you again for having me on this panel. That was my quick 10-minute overview of the two programs and some of the ways that we use data. And I really look forward to our future conversation, and I'll check and see if there have been any comments or questions while my next colleague talks about her programs and services. So back to you, Dr. Vick.
Great. Thank you so much, Dr. Moone. And I'll just say quickly that your idea of Tennesseans walking around with guitars and backup singers is really not too far from the truth. Hopefully you'll have a chance to come visit us and see for yourself once it's soon to do so. So thank you so much. And lastly, we're going to turn it to Kathy Laborde with the Gulf Coast Housing Partnership. Kathy, it's all yours.
Thank you, John, and thank you first to the folks at Habitat who reached out to me, I guess about 6 months ago, and invited me to join in this conference. I'm going to give you a slightly different take on this. Gulf Coast Housing Partnership, GCHP, we are a real estate developer and property manager. We're headquartered in New Orleans, Louisiana, and we operate along the Gulf Coast. Our work currently extends from Texas through Louisiana, Mississippi, and Alabama. We're in our 15th year of operation. We were birthed because of Hurricane Katrina, and we predominantly develop affordable housing and complementary community and commercial ventures, including healthcare centers and treatment facilities. To date, we've developed or preserved approximately 4,000 units. And of the units that we manage, about a third are dedicated to seniors. We typically will partner with service providers. And so we're bringing the service provider to a resident population. Specifically, for example, we'll partner with Volunteers of America right now in Alabama. We're partnering with Council on Aging in Baton Rouge. And partnership in the truest sense, these organizations want to own the real estate. So we bring them into the ventures, they provide the services, and during the unwind, they will end up with the actual units. Some of our Gulf Coast bordering states, Louisiana, Mississippi, and Alabama specifically, are areas of such great need, low incomes, and frankly, the bottom of the barrel with regard to health outcomes. Costs are high there. Across the board, wherever you work in this country, costs are high to build affordable housing, and in these specific states, rents are low. Therefore, you end up with a gap in building the requisite capital stack to fully source an affordable housing transaction. For those of you who don't really dabble in the real estate world, 9% low-income housing tax credits. That is the predominant financing tool for developing affordable housing in this nation. And those credits are awarded to each state on a per capita basis. So given the states that we're talking about with very small populations, they end up with very few 9% low-income housing tax credit allocations. Therefore, every year, very few new units get produced and very few old units get preserved. Therefore, our challenge in this arena is to bring more capital into these states because it simply isn't available locally. And for those of you that do operate in this world, okay, you'll certainly applaud the fact that the 4% low-income housing tax credit was quote unquote fixed at the end of the year. But that still doesn't solve the problem. It doesn't generate enough capital to fully fund ventures. So taking a step back and looking at the arena and looking at the states we operate in with no state or local resources other than federal money that is distributed through state agencies, our goal was to bring and is to bring additional and reliable capital streams to the region from managed care organizations that are operating in states through competitively awarded state contracts. We want to marry this capital stream with other sources of capital, such as the 4% and 9% low-income housing tax credit that I mentioned, new market tax credits, historic tax credits, and conventional debt. And your state may also have specific money that this could be married with. We want to use these capital sources to build affordable housing, and we're embedding healthcare providers on state. And states have different nuances, so this is reflected in different, call it, project types. We are also then concurrently affiliating with data collectors to quantify the healthcare savings resulting from our intentional building design. We're building these facilities to a Fitwell certification, which in theory is to result in better, quote unquote, healthier buildings, and then provide service provision on site. We were recently awarded $2 million from the Enterprise Wells Fargo Housing Affordability Breakthrough Challenge to support this initiative. Affordable housing investments are typically long-lived. We're using the funds to create a loan pool supported by a collateral fund and our GCHP's balance sheet. This will result in the ease of entry and departure from these ventures by managed care organization investors. And I'm shortening that up to an MCO investor will know they can retrieve its principal investment short of the project financing compliance periods should the MCO want to exit for whatever reason, most likely loss of the state contract. We're currently advancing 2 transactions, one in New Orleans and one in Jackson, Mississippi, with MCO commitments, 2 different MCOs. Both are funded with low-income housing tax credits. One is a 9% transaction, while the other is a 4% transaction. Both include seniors housing. Both embed a healthcare provider. In one situation, there'll be 2 on-site clinics, and the other situation, there'll be an on-site clinic. This particular venture in Jackson will also be partnering with the Jackson Medical Mall Foundation, who have worked in partnership with Jackson State University to promote a community healthcare worker. So we'll have the community healthcare worker embedded on site. We'll have Jackson State University and the Medical Mall Foundation collecting data. And then the clinic will ultimately, at the end of a new market tax credit compliance period, will end up owning the clinic. And the group we're partnering with will own the seniors housing. So I am basically can say more about it and answer any questions, but this is truly all about intentionally embedding healthcare to result in better health outcomes that we can quantify to lure more private capital to develop affordable housing. And that's it, John.
Great, thank you, Kathy. Well, thank you to all of our panelists for providing an overview of their work. We are going to now start our panelist discussion portion of our session. So we have a few questions that we want to pose to our panelists. And then as you've had a chance to think about what you've just heard as a participant, please add any questions that you have into our Q&A or our chat, and we'll make sure to pose those to our panelists as well. So we've talked a lot about programs, and you've each touched a little bit on data and the role of data in evaluating and understanding the benefits of your respective programs. And I wanted to dive a little bit deeper and ask, in what ways and what types of data have you used both on the front end and the back end? So were there types of data that you had to share or to analyze to justify beginning your program? And then what data did you collect, and how are those data used to justify continuing your program? So essentially, what are the data sources that you're using, and how are you using them to justify both beginning and continuing your program? And so I wanted to pose that to each of you. Maybe Alicia, if you'd like to start.
Sure. Data is a really complicated issue for housing properties. I'm sure many people out on the call today, on the webinar today, know that affordable housing properties don't generally collect a lot of information about their residents beyond the kind of income, eligibility, and demographic characteristics. It hasn't been a tradition for housing properties to do assessments and gather health or functional or social information about their residents. And partially that has been driven by, one, it hasn't been their role and to do anything about that or with that information, and also fair housing constraints and fear of butting up against that. But we have seen a lot of change in that over the past several years, where more residents, as they're trying to drive these more purposeful services on site, whether it's them delivering them, the housing property delivering something directly, or trying to entice partners and collaborations, they've started doing more assessment to gather this kind of information about what kind of needs and interests and issues do their housing property have. But this is a challenge in attracting or enticing the health partners, because they need to know that there's something that they can come in and address and solve. So that's the first data challenge, is having that information about residents' health and functional needs. On the back end, the challenge with evaluating the outcomes is that the housing properties still don't have that kind of information. They don't have the information on when the residents go to the hospital, go to the doctor, go to the ER, that kind of thing. So being able to evaluate that they're having an impact on those kinds of outcomes, reducing hospital stays, reducing ER stays, is really challenging to do, because they can't really get that level of data, that level of information. So, in some cases they can work with the healthcare entities. For the people that are in their system, they're going to have that data. So I think there really needs to be some more purposeful exploration of the data with healthcare partners, with housing properties, and to really know what the trends are, what could happen, what does happen. From a research perspective, we are able to go to CMS at a broad level with permissions and stuff to get that data, but that's not accessible to your average provider. So I think that's one challenge that providers, both on the health and the housing side, need to think about, and that's potentially a role where states could come in and help facilitate that kind of data sharing or gathering.
Great, thank you. Kathy, how about you? How did you use data to justify your work, and how are you using it in an ongoing way to evaluate your work?
Okay, well, first of all, I want to make clear, we're not data collectors, okay? And so I think, but though, from the outset, though, from the data that's out there, we know that the healthcare results evidenced by our existing population is dismal. So that's a fact, okay? And so what we're trying to do then is partner with data collectors as well as the MCO. The MCOs are already collecting the data, okay, on their populations, regardless of where they are. They may not be living in our housing. And to Alicia's point, yes, we do not collect information about our residents like that. We need to partner with folks, though, that do. And so our goal is that in collecting this data, which we'll be doing it through our partnerships concurrently with the MCO, who will be able to embed those high serve clients in our residential units, okay, and track the outcome. Our goal is that outcome, that quantifiable outcome, adds in the return to the investment that the MCO is making in the actual bricks and mortar. Okay. And folks know right now, some of you may know this, typically an MCO will come to us or come to others and say, we'll provide you rental assistance. Why do they provide you rental assistance? Because they want to house people, get them off the street, because they know in doing that, there's a better health outcome. Okay, chances are maybe the person won't end up in the emergency room or some other high pay, high touch scenario. Our job is to collect that data so that we can prove this to a broader market, and that these things that become special projects or special initiatives because the MCO wants to go after state money, it won't be special, it'll be routine because it's in their own financial best interest to promote this.
Great, thank you. And Dr. Moone?
Yeah, thank you. So I think when looking at data, there are sort of different steps to data collection in the process of program development. And you sort of start out with data that you need in order to develop programs and make the case to implement the programs, whether it's to a state legislature asking for funding or a waiver or exemption from the federal government in order to do something new, innovative, and different and to test it. And then at the other end, you have the data that you collect in order to evaluate whether your intervention program or policy was effective. So on the front end, at the University of Minnesota, we have a center called the State Health Access Data Assistance Center, and it's available to all states. And it talks about a lot of the health insurance that citizens of states have access to. And it helps us understand how many people have access to private pay, employer-sponsored coverage, how many people are in public programs, who has access to different types of programs. And they also can work with states to develop profiles. And that was one of the most important pieces for us in making the case, was looking at Medicaid data and seeing our Medicaid expenditures. And what can we do in the next couple of decades to help sort of curb those costs or invest really wisely is important, because there is a reality that we have to look at budgets and the bottom line figures. But in addition to that, we have data from Minnesota that is available, I'm sure, across the U.S. on how ready are the baby boom generation for their healthcare and long-term care costs. We have a study here in Minnesota that showed that a quarter of baby boomers won't be able to cover their rising healthcare and long-term care costs in retirement. So that's another sort of data point. And then lastly, we have a couple data points that are more qualitative. Like I said, we have the survey of older Minnesotans that happens every 5 years, looking at preferences. And then all of our counties every 2 years and our tribal governments have to do a gaps analysis, looking at where home and community-based services are at in their communities, where they need to target some of their funds. So then on the other end of the evaluation, it's important to have things like a rigorous external evaluation, working with centers and organizations like L.N.H.A and Alicia, who have done these external data reports for organizations, and to have a really rigorous policy analysis. And those are things that need to be built ahead of time. There's things that you probably shouldn't do at the end. You can certainly tweak evaluations, but and I guess coming from a university, and there are many in Tennessee and across the US for people that are watching, reach out to people who know how to analyze and collect data. There are faculty who are looking for research projects. There are junior faculty, there are graduate students. These are great people that can help you with survey construction, data collection, and analyzing of data. So I guess that would be my recommendation is reach out. There are lots of people who are willing to help for free, and some who will do it for pay too.
Great, thank you. Thank you all. No, that was excellent, very helpful information. So definitely a focus on looking at the reduction in healthcare costs, but certainly an interesting role for needs assessment and qualitative data, and certainly for external partners who can provide that objective evaluation and outside expertise. Rajean, you briefly mentioned policy when you were talking just a moment ago, and I wanted to bring that up for our panelists as well. Are there certain policies at the local or state level that support this type of work, or have you noticed policy change as a result of the successes of the work that you've done? So I want to pose that first to Kathy and see if you have a response around policy.
That's a tough one, because I can't say that it's one thing to have a policy. It's another thing to have the money behind the policy. Okay. And so I think I don't want to dismiss any individual sincerity in trying to advance the cause, but it's kind of hollow if it's not followed up with real either money or initiative. And so I would say, and that's frankly why we're doing what we're doing. There's affordable housing, I think, is a priority, quote unquote, in most states, because there's so many people that need it. But it's not enough of a priority for states to actually put their own dollars up. Okay, they're putting up federal dollars. They're not putting up state dollars. And so that's a real challenge. It's a real challenge. And so what we are trying to do, frankly, the more we can quantify, and I would say GCHP kind of acts as a collector, okay? Collector of groups that in isolation, they may be having great success, but they're not really able to scale because their success isn't recognized. You know, for example, this community healthcare worker model in Jackson, which there is data that supports that there are better health outcomes with this community healthcare worker embedded and working with a population, but nobody wants to pay for it. So, you know, where the rubber hits the road, ideas are terrific, but not back with money. And I think that's why at GCHP, I can dream about this day and night. We have to bring the money to the table to help our states get there.
Great. Yeah, that's an excellent point. Alicia, any thoughts on policy?
Yeah, I sort of echoing Kathy. I think she makes some great points about kind of the policies, but not really following them up with the actions. And I think, you know, we have had a lot of policy shifts, some degree rhetoric, you know, some not over the past several years around the importance and the recognition of social determinants of health and their role in health. And we have a lot of healthcare systems and a lot of healthcare entities that are echoing that, but the money is not really shifting or expanding for these social determinants of health. You know, whether it's housing or food or transportation or what. And in addition to the money, there hasn't been a lot. We're still putting that responsibility largely in the healthcare sector, rather than really forcing or incentivizing or encouraging the healthcare sector to partner and work with the community-based organizations that know those various social determinant of health elements well. That's what they do. And so, and know the individuals that they've been working with in their community as well. So I think from a couple different perspectives, there needs to be a little more action behind this policy idea. I also, you know, picking up on what Rajean said about, you know, 80% of people don't want to move into a nursing home, probably more than that. And states have really been putting a lot of emphasis around, and the federal government around, shifting the balance from institutional care to home and community-based services, but there's still a lot of money. The bulk of money is still in that institutional care. And there, you know, kind of going back to the social determinants of health, there's still not a lot of money put into building up those community systems that would support bringing people out of the nursing home or keeping them out of the nursing home in the first place. Whether it's, you know, housing or the home and personal care services or what that may be.
Great. Yeah, also excellent points. Social determinants are becoming more a topic of interest and a focus, but maybe the policies and dollars are not shifting in that direction yet. Rajean, anything that you'd like to add to the policy discussion?
Yeah, I mean, I think policy change can equate to a sustained commitment and sustained commitment to change. So getting to that policy is often important, right? It doesn't just become a demonstration project. It becomes cemented into sort of being. I think what Alicia said really hits very close to home, that healthcare does receive a significant amount of funding. And with policies like the Affordable Care Act that is attempting to look at things like social determinants of health, those providers of programs and services that impact social determinants of health, many of them do not have the infrastructure to even interact with a health plan, who requires, could require many pages, some of them 100 pages long, agreement to be a guaranteed provider. We formed a collaborative here in Minnesota called the Juniper Network that basically serves as a fiscal intermediary for over 150 nonprofits across the state who offer evidence-based health promotion programs to be able to contract with health plans through that fiscal intermediary through Juniper Health, so that a tiny church way out in International Falls, Minnesota, where I was born on the Canadian border, that has no way of billing a huge, Blue Cross, Blue Shield of Minnesota Minnesota, but wants to do a falls prevention program that's been shown to help people, like Matter of Balance, they now can join the Juniper network, and then Juniper can fight the big beast of the health plan to get all of the required signatures and then be able to funnel the funds for anyone who's a Blue Cross member participating in that falls prevention program in International Falls to get money to that church to buy supplies and do the work that's needed. So it's going to be a huge change. And in case people didn't know, we had an inauguration yesterday, and I think there's going to be some pretty big changes going back, the pendulum perhaps swinging a little bit back more towards the Affordable Care Act, and how can we do some of these demonstrations through Medicare, through CMS and CMMI. Those are the organizations and divisions within the federal government that oversee Medicare and Medicaid. So really excited at the opportunities.
Thanks, Rajean. And we did have a follow-up question from one of our participants. They asked if you could talk a little bit more about how you've maintained that diverse stakeholder task force to move ideas into action.
Yeah, the Minnesota Diverse Elders Coalition. So it's an organization that has actually received private philanthropic funding. One thing we found from private philanthropy is they really like to invest in new things. And they like to invest in things that do attempt to mitigate and reduce these health, social, and economic disparities. So we were very honored to be able to receive some grant funding from a foundation here based in the Twin Cities to be able to hire a leader, a coordinator of that group. And what was important with that coordinator is that she be from the community themselves and understand the narrative of the people experiencing these systemic disparities. And so this group is still in its storming process, but with the backbone of the Minnesota Leadership Council on Aging, they have that extra administrative structure, that extra partnership to be able to continue that sustained planning and to be able to write grants. Because the Diverse Elders Coalition isn't at a place where they could write grants for themselves just yet. So they rely on that leadership council. And we were very excited that our commissioner of our state Medicaid agency, the Department of Human Services, now has had 3 meetings with the Diverse Elders Coalition to ask their feedback in policy development that she and her department are bringing forward to the state legislature. So once you get your foot in the door with those important people at state agencies and you have some funding, and you bring a small group of committed people together, it just sort of grew like wildfire. Disparity work and equity, diversity, equity, inclusion is hot right now. People are really interested in it. And you know, in Minnesota, unfortunately, we've been slow at it, and it really took the murder of George Floyd that happened here in Minneapolis for us to really face this head on and say, we need to make societal and policy changes in order for Minnesota to be that great place to age. So it's perseverance and the right people around the table, and a little bit of funding always helps.
Great, thank you. All right, so we have another question from our attendees. This one is for Kathy. This attendee says, it's exciting to hear about your projects with MCOs. Does Medicaid in those states have policy or contract requirements that enable MCOs to make these types of investments? And they're wondering how MCOs in other states could replicate these types of investments.
Yeah, this is in no way initiated by the state. What we discovered was that, you know, with these state contracts are awarded competitively. So what the MCOs are doing, and I have not read the actual RFPs, the state solicits, the state distributes, excuse me, but there is some response due from the MCOs and how they're benefiting the community. Okay, so they like to, you know, that's probably why they're going to knock on your door to provide you rental assistance, so that they can then embed this in their response on an RFP on the state contract to talk about the investments they're making in the community to advance better health outcomes, right? So in that regard, I would say a question on an RFP is helpful in advancing that MCO participation in a state. I will also share with you that some MCOs are already doing this routinely, okay, not in all states. So it does involve you just advocating for this, getting in front of these groups. The unfortunate thing is that when you first start meeting with these people, you're really meeting with the sales side of the, because they want to win the contract, right? And which is fine if you get their attention. What we're trying to do, that's why I said, we don't want this to be a special project based upon an awarding of a state contract, right? We want the treasurer, the corporate treasury departments of all these MCOs to say, oh, routinely, we're going to invest X millions of dollars in affordable housing this year, because we know the outcome is going to advance, our own profitability, right? That's what we're trying to do. And so I would just encourage you, the MCOs are out there. They are participating, some more robustly than others. But it's really not being, and I will say this too, I would suspect, because I don't know all states, my guess is some states are incenting this. I'm just not sure which states they are. Okay, our states are not in that number.
Great, thank you. Let's see, we have another question. This one was in the chat, and I think Rajean, you mentioned you wanted to provide an answer for this. So it's, let's see, it was about, let me find it here.
Oh, it was a tough one, and I'm not sure I wanted to provide an answer.
Yeah. Well, I'm going to throw it out anyway. We'll just see what we get. So it's when older citizens decide to stay in their homes, and even when support is given, they still have the burden of other costs like taxes and repairs. So their income was considered middle income, but as time goes on, their income begins to decline. And so are we actively helping those individuals that prepared for a decline in life by saving, but their income can't sustain the increase to live comfortably?
Yeah, I think I can offer some comments, and perhaps Alicia has some ideas from her experience in other states, but I don't think that there's a universal, there isn't necessarily a universal answer. It's really an individualized, person-centered approach of helping the person understand what's available to them and what is best for them so that they can make an informed decision about their life. And it could include things on the spectrum, everything from tax credits to investing some money in a burial account so that money isn't counted as eligibility for public programs, to things like reverse mortgage. They work wonderfully for some people, and for some people they are not the best option at all. And because there isn't an entitlement of a universal income in retirement, and there isn't an entitlement in the United States for housing, we've patched together this network of federal, state, regional, county, local, nonprofit service and support system to try and help people where they're at, but it becomes very difficult to navigate. So I don't mean to deflect the question at all. I think the answer is yes, but it's so individualized and person-centered that it's difficult to say that anyone who's middle income and maybe is on the line, this is exactly what you should do. Because everyone is so different, how much your mortgage is compared to if you're renting, if you have someone who has a chronic condition such as living with dementia, the stories are so different. So maybe I'll kick it over to Alicia, who for me is over there on my screen, and she might have some ideas as well.
Yeah, I might be doing a bit of deflecting as well, because I think this is a really complex question and a really important question. I think the person in the chat, I think they sort of made the point that, you either have money or you qualify for Medicaid, and it's that big group in the middle that really struggles, and that is dead on. And I think there's a lot of thought going into how to support that group now. There's been a lot of studies that I think Rajean touched on, or that have been looking at that sort of what's being called the middle market of people who may own their own home, may have some resources, but aren't going to have enough resources to really support themselves over the long term. So there's a lot of work going on looking at long-term care policies, social insurance policies that might be broader than Medicaid in terms of who they support or what kind of benefits or how they provide benefits. I think speaking to this from the housing perspective, I think one of the things that we need to think about is, and this is really challenging, is having broader conversations with people about what's the right housing setting for them. Should they be staying in their home long-term for various reasons? That doesn't necessarily mean moving to a nursing home, but it may mean, is there a different types of housing setting that may be more appropriate, or more comfortable, more successful for you? And part of doing that, though, is we have to expand our housing options in our community. Our housing traditions and our zoning traditions really lock us into apartment complexes in one area and single family homes everywhere else. And I think that conversation has been broadening. I think Minneapolis, right, Rajean, has had a big conversation on redoing their zoning to increase housing type opportunities. And I think that's part of the equations, is providing alternative options for people to be able to stay in their own community or their own neighborhood, but maybe in a home that works better for them, given their fiscal, their social, their functional circumstances.
Yeah, if I might add something too, I mean, it's a very simple thing, but and I see this a lot in neighborhoods that are gentrifying. Every state's different, right? But why can't senior citizens pay no property taxes? I mean, you set them up for failure if they're living in these existing neighborhoods. Most of the other houses have been abandoned. And I'm talking about neighborhoods, I mean, you know what they look like in many of our urban areas. And so there's success. You're able to lure people back into the neighborhood. What's the first thing that happens? Property values go up. Property tax assessments go up. Okay, then people that are living on very fixed incomes, their property taxes start to increase. They didn't do anything. They didn't move. As a matter of fact, the world around them is all of a sudden getting better, right? And that we want to kick them out because they can no longer pay the tax man. That is a policy issue, and that can be fixed.
Yeah, that's a great point. And yeah, I know that some cities, I believe Nashville is one of them, does have a property tax freeze option for seniors in certain neighborhoods if they've been there for a long time. So there are definitely some good policy solutions there. And yeah, I think the theme of this response is that there is no easy answer. This is a complex issue, and there's not a one size fits all solution. And I think, was it Kathy or Alicia just mentioned also, and is it Minneapolis that recently got rid of all single family zoning? So that's a very sweeping policy change that could have some impact for seniors as well. So let's see what else we have. So we have a few other questions here. Alicia, we have one for you. Someone mentioned that you talked about slowing Medicare expenditure growth in urban and city clients, but some of the attendees here represent rural areas. Do you have any insight on the benefit of SASH in a rural area?
Yeah, and so from a researcher perspective, when I was citing the results of that, I was citing what was statistically significant in terms of slowing the growth in expenditures. But in the SASH evaluation, we still saw the trend was a slowing of the growth. So I don't think we know that that's not what's happening. It just wasn't statistically significant in our study. And some of the founders of SASH have been working with some other communities to test it out in other communities. And in fact, in Minnesota, and they are incorporating it into some rural communities. I don't believe there's any outcome data there, but I think we think there's a lot of promise for SASH models in rural communities because of the potential for the housing property to be a hub for services to the broader community as well. And so not just people who live in the housing property, but the neighbors around. Our evaluation of SASH actually didn't look at community participants. We weren't able to do that for a variety of reasons, But so we don't know for certain that, we don't know one way or another what the outcomes were with people living in the community. But what we do know from our qualitative work around the SASH evaluation was that the SASH teams brought some services to rural communities where they didn't have any services before. So they were a way of introducing services and bringing in more resources. So I think it's, definitely valuable from that perspective.
Great. And Alicia had another follow-up question. Let's see.
Okay.
We have a lot of good comments in the chat, by the way, for everyone. Let's see. So again, for you, Alicia, related to Medicare savings, where are those savings reductions and resource savings being realized or redirected to now?
I'm not certain I'm understanding the question, but where with the SASH program, for example, where there were, this is a little bit of a challenge, and I kind of think it kind of goes back to this question of this policy question of where are we directing resources. Right now, those savings or slowing in the growth of expenditure stayed with Medicare. They accrued to Medicare. So one idea is that should these savings that are being benefited by the housing communities or whatever the community-based system is be plowed back into the communities? Could those savings be plowed back into building more housing, providing more rental assistance, supporting the teams that are delivering these services in the housing properties, the service coordinators, for example. To some extent, that probably is what's happening with Vermont. In Vermont, they're probably to some extent funding the SASH teams with the savings that the SASH teams are generating. But I think we need to think about it from a broader policy perspective of if we're able to spread and create sustainable, replicable models that of these types of strategies that we could incorporate in housing properties across the country, where do those savings go? Is an important policy question. John, I wanted to mention one other thing that I forgot to mention in my talk. I just wanted people to know, if they didn't know already, that HUD over the past 3 years has sponsored a national demonstration called Integrated Wellness and Supportive Housing, I wish, that incorporates that is designed to test models of enhanced services in affordable senior housing properties. And it incorporates many of the elements of SASH into it. That was a demonstration, and there will be an evaluation that was funded for 3 years. And then it was just extended in the most recent budget that was just passed for another 2 years. So I just wanted people to know that there's a conversation at the national level, some level of conversation at the national level around the potential for these kinds of strategies. Right now, all of that is funded by HUD, but we hope that it would lead to a conversation with the CMS, the Center for Medicare and Medicaid Services, about what's the potential role for Medicare and/or Medicaid in funding these types of models.
All right, great, thank you. I think we have time for just one more question before we start to wrap up. Rajean, this question is for you. Says you mentioned that Minnesota leadership that made elder support a priority. How do practitioners advocate to help inform leadership who are not yet aware of the importance of elder support?
That's a great question. So just a little bit about the Minnesota Leadership Council on Aging. In Minnesota, what we found at the policy, we really, as aging service providers, needed to rely on the actual state government to advocate for what they want. And we know that state government should be advocating for its citizens, but they also have their own sort of self-interest in how they advocate. And then there was very strong advocacy for the nursing home trade associations. And there was a lack of system-wide policy and coordination with more of the home and community-based services across the spectrum. So about 15 years ago, the Leadership Council on Aging formed with organizations like the Area Agencies on Aging and AARP, the Alzheimer's Association, major home and community-based service providers, you know, of long-term services and supports for older adults, to come together for common ground to work towards this positive systems change for older Minnesotans and their family members. So the Leadership Council itself has an executive director. I was privileged to serve in that role for 5 years before making joining the dark side in academia and leaving sometimes what I think the real world is behind. We like to stare in the clouds sometimes in academia and need to be remembered that there are implications for communities for the work that we do. That Leadership Council has found its voice and is called to advocacy tables. So if you're interested in increasing the voice of certain sectors, the best thing you can do is set the table that people can come to. And if people have the will and the interest and the passion to advocate for things, people will keep coming to that table. I'm always amazed when I send out emails inviting people to conversations to collaborate on something that people show up. And sometimes I'm dumbfounded that people show up. I wonder why they show up. But you know, this idea that if you are passionate about bringing the voices of practitioners to the systems and policy level, sometimes it's not the policy people that are going to be reaching out to you asking your opinion. Sometimes you have to raise your hand or set the table and bring the policy people to your table, to your conference, and help inform them through, I wouldn't say subversive, but you know, mutually agreed upon ways that you want them to understand your position. So it's a great question.
Yeah, and I think that's a great note for us to end on, that spirit of collaboration. And sometimes it can be as simple as just inviting everyone to the table to start that discussion. So thank you so much. Before I turn it back over to Dwayne, I just wanted to say thank you again to all of our panelists, and thank you to Memphis Habitat for inviting me to moderate this. I'm humbled to be here. This has been a fascinating discussion, and I appreciate the opportunity to be a part of it. And Dwayne, I'm going to turn it over to you to close us out. Thank you.
All right, panelists and Dr. Vick, thank you. That was amazing. I just wanted to share a few of my takeaways. First, I love the idea of low-income seniors paying no property taxes. We definitely need to be working on that one. Also, Alicia was sharing that 8 out of 10 seniors want to stay in their homes, but only about 5 out of 10 believe they can actually do that. And so that's a part of the effort that we're working on right now. The seniors we serve here in Memphis, you know, all these folks want to stay in their homes. But unfortunately, I would probably think that the majority of the folks that we serve would stay there regardless if we were able to do an intervention for them. So that's just how dramatic this is and how significant it is that they want to, you know, stay in this familiar space for as long as they can. But most of them would never have the ability to do any sort of repairs. Our seniors are considered very low income. And so the work that we're doing is just really important. I love that Rajean shared that disparity work is very hot right now. And I believe that is true. So our efforts to engage is timely. Advocacy and awareness is extremely important at this moment. And so thank you again, panelists, for helping us to start these conversations and start engaging. We appreciate it. I just hope that we'll see all of you continuing to engage with us and tune into these sessions. The next one will be next Tuesday at 10:30, once again. And that session is going to dive into the healthcare case for age-friendly housing interventions. So again, thank you, Dr. Vick. Thank you to our panelists. I'm happy to see all of you here. Thank you for tuning in. And also be on the lookout for an email from our team by the end of the week, where they're going to give you access to this week's videos, the presentations, and links to any of the resources that might have been mentioned during the conversation. So thank you again. everyone, and have a wonderful afternoon. We'll see you next week. Thank you.